Okay. My question is for Dr. Sikora. I have a daughter and her family that live in London, and they've been there for 11 years. They love it. And I asked her a couple questions about the healthcare system there, and I'd like to ask if you have any information on this. Number one, she gave me a website, the Cancer Postcode Lottery, and explained the fact that if in a zip code they've run out of cancer drugs, even though they might have them 3 blocks away in another zip code, the people that live there cannot get access to those drugs. Is that true?
It's not quite they run out. It's because there are 152 of these primary care trusts that are independent decision makers, that for certain drugs that have not been approved centrally, it's up to each individual PCT whether they'll approve it. Now, whether they approve or not, they depend whether they have the money and the budget at the time of year, and whether they feel they'd rather support cancer versus maybe some other aspect of healthcare. And that's the problem. It's the vagaries of the system.
Okay, I guess I was thinking more of the allocation rather than what they had.
Exactly.
Well, and then we see that, for example, breast cancer is the rate of cure is about in the 60% percentile versus what we have a much higher rate here in the United States.
Doctor, is that your impression? Our numbers would indicate that if you have early detection of cancer in the United States...
Absolutely.
Do you have any percentages on that?
Yeah. I mean, the early detection of cancer is greater in the U.S. than Europe, and I think one of the good things about the government-run service, it can do prevention and screening programs very well. So our breast screening program is a population-based screening program based on call and recall. And it covers 90% of the population come forward for that. So that's just been a tremendous achievement that can only be done, I guess, in a government service. But governments are great at public health, screening, prevention, education. They're not great at delivery of care. That would be my observation.
Okay. Then there was another question that the expectation of getting these drugs, experimental drugs, and particularly with cancer, that if a patient decides that they want to they go to a private doctor in the UK, they can get access to these experimental drugs. They pay for them, and then they cannot go back into the public sectors to get just the regular drugs. Is that true?
That's changed slightly. Last year, there was a review on what are called top-up payments. And exactly that. You have the regular drugs from the government, NHS, and then you pay privately to have what are called the top-up drugs. And that has now been approved. Our government did a U-turn during the autumn of last year and agreed that that would be the case, because there was quite a lot of an outcry that the people that want to top up their drugs, they've paid for they've paid their taxes for their NHS drugs, so why not let them top up? And the public didn't object. It was the ideologists, mainly to the left of centre, that objected to this inequity.
I think that was a good idea, and probably that shows the power of objecting to things like that.
Exactly.
Then just the other one is that with having to go to the private doctors, and my daughter said, well, you can go to the public sector, you can get an appointment if let's say you've got a rash on your arm, you go to the doctor and they say, yes, you need to see a specialist, we will refer you. You can get that first appointment right away, but then they say, well, it's 18 months when you can get the appointment with the dermatologist.
Yeah, there are huge delays. For cancer, they've been corrected. We now, but the trouble is, you have to know you have cancer. In other words, if the lady has a breast lump that's clearly, to the general practitioner, feels like malignant, she will be seen and treatment will be started within 2 to 3 weeks. But unfortunately, for many illnesses, dermatology, getting a routine dermatology appointment, as you say, can take up to a year. And if that's the case, then it's a melanoma, then you're going to delay a cancer diagnosis.
She also gave me access to a wait list on the website, so I went on that, and it was like, for a hip replacement was a year, for a knee replacement was 10 months, for a slip disc was 5 months.
I think
there must have been a lot of hits on it because now it's been taken off the website.
Yeah. I mean, the wait lists have been addressed by the current government. That has been a triumph. On the wait list now, the target is 18 weeks, and I think I saw the data yesterday, 90% of the population waiting for surgical operations get treated within 18 weeks. But 18 weeks is still a long time, and I don't think Americans would wait 18 weeks for a lot of surgery, some of which could turn out to be cancer.
No, I think you're right. I think we're we are impatient people maybe, but we also, want to be given. We're used to our healthcare system as working and being taken care of right away. Thank you very much.
Thank you. Mr. Johnson.